talking about insomnia, and having had the luxury of doing a full year's worth of clinics in my job as a sleep fellow at Monash Health last year. Probably wasn't something I jumped at the opportunity for, to do a year of insomnia clinic every week, but at the end of it, I was very glad. And certainly going out and working as a sleep physician this year, it's been extremely helpful for a lot of our patients to be able to use those techniques that you get from the clinical experience. So insomnia, what to do when they can't sleep? The very simple meaning of insomnia is sleeplessness, or no sleep in Latin. But I guess from a broader sense, and what we really try and elicit in our initial consults with these patients is, what type of insomnia do they have? Do they have insomnia itself, or is there another sleep condition? Or is it simply a condition where they don't sleep enough, or possibly don't need to sleep as much as they believe they do? And so part of our history is ascertaining, where does the issue actually lie? Is it a problem with getting to sleep? And so sleep onset insomnia is defined by being unable to fall asleep for over 30 minutes on a regular occasion. Or is it a problem staying asleep? And so that's once awake through the night, not being able to get back to sleep for more than 30 minutes, or waking more than 30 minutes before your desired wake time. And often, and I'm sure you've experienced this yourself with your own patients, that it's often a combination of both sleep onset and sleep maintenance insomnia. It's also important to differentiate between acute and chronic insomnia, because the treatments are very different. Acute insomnia is where symptoms are present for less than 3 months, and that they're associated usually with a very clear life stressor. And typically, if that stressor starts to improve, then the insomnia itself will improve at the same time. Very different to chronic insomnia, which certainly affects a large proportion of our adult population at around 10%. And that's when those symptoms linger for over 3 months. The most important part, however, is that it's regular symptoms. So for at least 3 nights per week for more than 3 months, that it occurs despite providing yourself with an opportunity to sleep. So not restricting your sleep because you're up playing games or working, but actually trying to sleep and being unable to do so. And the most important part, which is the clincher for a diagnosis, is that it's actually impairing your daytime function. And usually it's in the absence of another sleep disorder, but that's not always the case. So the things that we have to work out is there another sleep disorder? Does that need to be investigated, managed first? And then once it has been investigated and managed, is there still ongoing issues with insomnia beyond just the initial sleep disorder that we found? It's important to know what isn't insomnia. So that daytime function really is the clincher of the diagnosis. Like I said, there is a group of people who just can sleep and can function on very little sleep. And so those are known as the short sleepers. The Australian Sleep Association's definition of an appropriate amount of sleep is essentially what you need to be able to function during the day without any symptoms. And then there's the other group, which is the sleep restriction group, who usually by choice, but sometimes for other reasons, simply do not get enough time in bed. And as a result, are unable to function during the day. But typically, the best way to ascertain if your patient falls within that group is to ask them on a day when they are able to get enough sleep, or when they're able to sleep in on a weekend, do they feel the same way during the day, or they actually feel a lot more refreshed? I think the symptoms of insomnia are usually well known, especially overnight. So it's those frequent difficulties falling asleep, and then also awakening during the night with difficulties returning to sleep. But over time, and especially as we get into that chronic insomnia timeframe, we start to work out that there is a lot of anxiety around sleep. There's a lot of stress about the concept of sleep time. And what happens, particularly in the sleep onset group, but really in both sleep onset and sleep maintenance, is a lot of clock watching. And you say that to the patient, they immediately know what we're talking about, because it resonates with them so strongly. And it's the moment they're struggling to get to sleep, they start to worry about the fact that their wake up time is approaching nearer and nearer. And then they start to look at the clock and really work out how much time, and doing those calculations in their head all night, how much time do they have left to actually get enough sleep? Obviously, that leads to increase in anxiety, and it's a bit of a revolving cycle that can only make the situation worse. The daytime symptoms of insomnia also fit with anyone who gets a poor night's sleep. So it's fatigue and irritability, it's impaired attention and concentration, your mood is disturbed, you can obviously have increased levels of anxiety and stress, but it does affect your work performance as well. And I think it's important to recognize the risk factors for insomnia. There's the predisposing factors, and so genetic factors in older age are often very easily identifiable. But one that's important for us to recognize is the inappropriate expectations about sleep, and really trying to elicit from our patients, what do they expect when they go to bed? How much sleep do they think is appropriate? Where those expectations come from, and whether they're actually a realistic expectation or not. Often the underlying anxiety and stress about sleep and sleep time comes from those inappropriate expectations about sleep. There's also the factors that sort of precipitate the insomnia. And so that's the poor sleep habits or sleep hygiene. And we'll definitely spend some time today talking about how we address sleep hygiene. Very commonly, there is stressful life events that can be the precipitating factor, but then the insomnia lingers well beyond that stress. Medical conditions and pain, menopause, as well as other health conditions can all impact on your ability to sleep, as can issues that affect the circadian rhythm. So whether that be shift work, often switching between nights and day shifts, as well as travel between different time zones. It's important to also recognize the impact of caffeine and alcohol, and working out when and if patients are using those substances or other illicit substances that could be affecting their sleep, because that's often quite an easy fix. And then there's the perpetuating factors. And this is sort of what we were alluding to before with those nighttime features of insomnia. It's the people who, once they have issues with their sleep, start to get anxious about their sleep, which perpetuates the issue and makes it worse. There's the counterproductive compensations, such as increasing your caffeine intake to get through the day, but then affecting the quality of your sleep overnight. And like we talked about, those misperceptions and dysfunctional beliefs about sleep, which then feed back into those same problems. And so, why is insomnia important? Well, we know that it can affect your decision making through poor attention and concentration, but probably more important, sleep and poor sleep in general can lead to increased weight gain, heart disease, diabetes, and obviously the main risk of increased risk of motor vehicle accidents as well. This is probably just as important a slide as any of the others, and it's actually working out, is it insomnia or not? Um, Insomnia is very much a diagnosis of exclusion. You really have to delve deep into the history, work out whether there are symptoms of other sleep disorders that may be present, and rule those out before you can say that the patient has, true insomnia. Some of those conditions, like we talked about, are sleep restriction and short sleepers. The very common one that we see is obstructive sleep apnea, but all sleep disordered breathing can lead to features similar with insomnia. And I think it's important to recognize that there is a large group of patients that we see that don't have the typical features of sleep disordered breathing. They're not snorers. They haven't been witnessed to stop breathing overnight, but they have very subtle features, such as waking with a dry mouth, for example, that indicate that maybe a sleep study is warranted. And then we see quite severe sleep apnea. And in fact, it was probably the driver of those insomnia features all along. Similarly, restless leg syndrome can cause insomnia type features. And the ones that are often misdiagnosed as insomnia are the circadian rhythm disorders. The delayed sleep wake phase disorder in particular, where patients will over time develop a later and later wake time. We often see that in our late teen and early adult or early 20 population who are typically in university, having got some freedom from the regular scheduling of school and also the parental and teacher policing that comes with that. And suddenly are staying up later and later, whether they're studying or doing something else. And then over time, that is pushed back to a later sleep time as a direct result, sleeping in longer and having a later wake time. And then they come to see us sort of in the final 6 months of their university degree, worried about how they're going to re-enter the workforce because they're suddenly waking up at 12 o'clock every day. And so really, it's a very different condition with a very different treatment regime. And it's important to work that out from, is it insomnia or not? And who needs a sleep study? Well, I think it's often quite clear that there's other symptoms, and those patients, typically when they're suspecting another sleep disorder, such as sleep apnea, should certainly get a sleep study. But it's also important to think about when standard therapies for chronic insomnia haven't improved sleep or haven't improved sleep to the level that we thought they would. We then start to think, is there an underlying silent issue, such as silent sleep apnea, when none of the typical features are present, but in fact the patient is stopping breathing on a regular occasion? So we'd like to spend a bit of time today just talking about how we're going to manage insomnia in our patients and how do we improve their sleep quality. But I think these tips on the whole are excellent for everyone in day-to-day life. Our approach to managing insomnia tends to follow a stepwise regime, starting with sleep hygiene, and very rarely do we ever need to get to the point of using medications on any regular basis. And the most important thing is developing healthy sleep habits in order to try and prevent insomnia in the first place. But also, as soon as those initial features of insomnia develop, getting on top of the sleep hygiene to try and nip it in the bud as early as possible. What that means is having a very consistent sleep schedule, and in particular, very consistent wake time, maintaining a healthy lifestyle, avoiding alcohol and tobacco, avoiding meals that are too late. The screen time is incredibly important and getting more and more important as we become more reliant on screens, and avoiding taking naps, particularly when you've started to notice that they are impairing your daytime sleep. So screens emit what's known as blue light, and historically our major source of lighting as the human race was very natural. It was from the sun, and ancestors would spend their days in the sun in the natural light, and then the evenings would go into relative darkness. And as a result, your natural circadian rhythm would function on that light and then night schedule. Now that we've introduced artificial light, we've impaired on that circadian rhythm already. And in the last couple of decades, the increase in use of blue light has made that a lot worse. So we know that during the day, blue light is very beneficial to boost attention, mood, and reaction time. But at nighttime, it has the exact same effect. So suddenly it suppresses melatonin secretion, increases that level of stimulation, and as a result, causes a shift in your circadian rhythm. Blue light can be found on any screen in particular, although the white light features of LED lights that are more and more common in homes these days also emit blue light. And so we try and initiate some practices to minimize the amount of blue light that we're experiencing, particularly in that last 1 to 2 hours before bed. That can be using dimmer or redder lights, particularly in lamps that you can control, avoiding your bright screens. So that includes TV, iPads, computers, phones. If you are going to use them for whatever reason, then trying to use the blue light filter on those devices, which most devices have these days. There's conflicting evidence to whether that is truly helping or not, but certainly isn't causing any harm and is worthwhile trying. Blue light blocking glasses exist, and some people use those to very good effect, particularly when they can't avoid blue light altogether due to work reasons, amongst others. And just as importantly as avoiding blue light is actually exposing yourself to as much natural light during the day, during normal daytime hours. The Sleep Health Foundation put out these 10 tips for a good night's sleep around 2020, just as COVID was coming in, which has certainly played havoc with a lot of our patients' sleep cycles. And what they've said is really re-emphasizing those points of having a very regular sleep pattern, spending the right amount of time in bed, which is the amount of time you need to be in bed in order to wake up feeling refreshed the next day and to get through the next day without function. Another important one is to minimize the amount of time spent in bed for non-bedtime activities. And what that means is the bed is for sleeping and for sex. and not for entertainment. Really spending some time winding down and relaxing before going to bed, making sure your bedroom's as comfortable as possible, and that includes temperature as well as noise. Avoiding alcohol, caffeine, and cigarettes, particularly in the afternoon hours. Avoiding daytime naps. And like we said, don't lie awake watching the clock. So when your patients do admit to clock watching, some of the techniques that we put into place are: one, remove the clock from the room, or at least from reach within the room. If that's not successful, actually encouraging them to get up and go to another environment away from the bedroom until they fall sleepy again. We do like to avoid sleeping pills except for in exceptional circumstances. Now, certainly, this we're talking here about chronic insomnia. There is a role for sleeping pills in the acute insomnia phase, but we'll talk about when and if we would use those. Some of the other sleep hygiene actions that we do initiate sometimes, and we really work these out based on the history from our patients. So if the reason they can't get to sleep or stay asleep is because they're worrying about either their daytime stress or other related matters, we actually get them to schedule in some worry time before bed. And for a lot of people, this means sitting down and journaling about those worries for 15 to 20 minutes. For other people, it's just sitting there pondering or meditating on them, trying to resolve them with themselves before going to bed. Another fact is to try and avoid going to bed until they're drowsy or ready to sleep. Try not to force sleep. So if you're not asleep within 30 minutes, getting up, going to another room, doing something that's quiet and not very stimulating, such as reading a book. And then when you're feeling sleepy again, going back to bed to try and fall asleep again. And usually we would encourage our patients to actually have this set up before they even go to bed. So a dark room somewhere else in the house, probably with a small lamp and a book next to it, or whatever your non-stimulating activity is. And in your bedroom, have your dressing gown ready to go, so that when you get to that 30-minute mark, and it's purely subjective because we don't want them looking at the clock, but when they feel like they've been in bed for around that time and aren't falling asleep, to get up and go to their quiet area, try and see if they fall sleepy again. When sleep hygiene alone and improvements in sleep hygiene alone aren't effective, we then step into the behavioral therapies. The brief behavioral therapy, or BBTI, is often very effective and often all we need to do for our patients. Both BBTI, brief behavioral therapy, as well as CBTI, cognitive behavioral therapy for insomnia, are very effective, but they also require an extremely high amount of discipline to get through. And trying to initiate the bare minimum of actions to maintain that discipline is important as the action itself. So BBTI is successful, and what we really focus on is restricting the amount of time that our patients spend in bed. And so the way we work that out is to think about their average sleep time, and in particular, how much sleep on average they would need to wake up feeling refreshed, at about 30 minutes to allow them time to get to sleep, and really ensure that they're not spending any time in bed outside of that. We will continue this for 2 weeks without any adjustments, and then we will review to see whether or not we should increase or decrease that average sleep time. And we add to this stimulus control. And that's really what we've already talked about in terms of having a very strict sleep schedule, especially in terms of your wake up time. And that includes on weekends, weekdays, when you're working and when you're not working. Only going to bed when you're sleepy, as well as staying in bed only when you're asleep. So getting up as soon as you notice that you're not drifting off to sleep as quickly as you would like, and then returning to bed once that sleepiness feeling comes back on. When BBTI has been unsuccessful or failed to get a complete response, then we look at a bit more of an involved process through cognitive behavioral therapy for insomnia, which I'm sure a lot of you have already heard of and probably use on a regular basis. We know that CBTI has been shown to be superior to medication alone in both short and long-term studies in insomnia. It's the first-line treatment that most sleep societies and guideline panels recommend for chronic insomnia, and it's a multi-component approach, but the key factor there is that it's delivered by specialist sleep psychologists over around 4 to 8 sessions. It's very different to CBT for other reasons, both in the way it's delivered, but also the actions that are taking place. I think it's important for us to recognize that there are studies that show that online programs are effective for the patients that are extremely disciplined and have standard issues with their sleep. But the use of a specialist sleep psychologist certainly increases the efficacy of these programs beyond what an online program can deliver, even though in theory the actions are very similar. In very brief detail, because there is a lot more that they do, the sleep psychologist will go through both to improve their sleep using both areas. Sleep restriction is the absolute basis of this and can be extremely aggressive. The way I put it to my patients is that we need to break your sleep in order to fix your sleep. And so, where we start is, what is your desired wake time? And we work backwards from there in order to get you to the total amount of hours that you feel you need in order to wake up feeling refreshed the next day. And so, purely as an example, if our patient wants to wake up at 6 a.m. every day, then that is their wake time for the entire duration of CBTI. And to start with, we restrict their sleep, and it can be as little as 3 to 4 hours. And so, what that means is they can't go to bed until 3 a.m. In order to get up at 6 a.m. And so, they have to stay up for as long as they can. At 3 a.m., they can go to bed. Hopefully, they sleep through, but if they don't, they're still getting up at 6 a.m. And they do that for a few nights. And what they're building is sleep debt. And over 1, 2, 3, 4 nights, very rarely 4 nights, they'll have a night where they crash, where the sleep debt takes its toll, and eventually they'll sleep through the night and probably fall asleep well before that 3-hour mark. We get them to do that a few times, and when it's been established, we then pull that back to 4 hours, 5 hours, 6 hours until we get to the point where they're waking up feeling refreshed and hopefully staying asleep through the night. That's the basis of CBTI, but it's not all they do. So we also institute the other behavioral components such as stimulus control and sleep hygiene, as well as trying to deal with the cognitive components of poor sleep. And so that really looks at the anxiety and the catastrophic thoughts that come with sleeplessness, the expectations around sleep and trying to address those, and also trying to improve relaxation in the period before sleep. Bright light therapy comes up every now and then. It's very well recognized in people with circadian rhythm disorders as a very well established treatment. In insomnia, particularly in sleep onset insomnia, it's used to try and increase exposure to bright light in the mornings in order to advance circadian rhythm to that desired sleep onset time. And likewise, for people who wake up too early, you can use bright light in the evening to try and delay that wake up time. Finally, when would you consider medications? Certainly, when there's been a stepwise approach through the management steps, we've ruled out any sleep or medical disorder or optimized them as much as possible. We've balanced the risks of untreated insomnia with medication side effects. And when all those boxes have been ticked and there's been a failure to respond to those treatments, we then can start to consider whether medications are the next best step. As you'll all be aware, there are risks and benefits to sleeping pills, but there's also risks to not having good quality sleep. And so it really is about finding that balance. The daytime drowsiness and reduced cognition and reaction time from the use of sleeping pills is certainly important, as well as the risk of dependence and tolerance, which we see more and more. But likewise, in patients who are unable to sleep for prolonged periods of time, it decreases their quality of life. It increases the risk of other medical and mental health issues, as well as substance use disorders, and decreases their performance in their daily tasks. We will frequently see patients who've tried over-the-counter medications, typically before they've sought any medical help. Rest of it is one that we see a lot of, but other antihistamines also exist. Really, they're intended for short-term use only, and so they're targeting patients with acute insomnia with a clear stressor, and that stressor dissipates in a short period of time. If they are to be used, they certainly should be used in conjunction with all the other non-pharmacological techniques that we've discussed. And it's important to look at their interactions with other medications because there are plentiful. Some of the sleep supplements, such as chamomile and St. John's wort, also exist, often in combination with each other. Again, interactions are probably just as important here. The jury's still out on melatonin. There's certainly a small group of people where it is extremely effective, but likewise another group where it has no impact whatsoever. In insomnia, the evidence is minimal. It's generally considered to be safe and works best when it's taken about an hour before bedtime. There's been a large systematic review published in 2020 that showed that it did improve sleep latency and total sleep time, but the clinical meaningfulness is unclear because of this very small effect of melatonin on both those factors. And it's also important to recognize that there are side effects to melatonin, despite it being a relatively safe medication. The big one being vivid dreams and nightmares, but even during the day, patients can become dizzy. They can struggle with daytime sleepiness, although not to the same effect as other sleeping medications. And stomach cramps and low mood are other factors that our patients do recognize. And then we move on to those prescription medications. So the benzodiazepines and Z drugs, but also relatively recently, we've had an orexin antagonist into the market in Belsomra or suvorexant. They're all very similar in their approach, although dependence becomes less and less with Z drugs in Belsomra. Our approach tends to be to try and use them for no more than 4 weeks at a time, typically in an intermittent basis rather than nightly, and really counseling our patients around their use, the lowest dose possible. And probably the most important factor with these medications is really devising and ensuring that everyone's aware of what the plan is to withdraw them and when that withdrawal is going to occur before we even start them. A couple of off-label medications are certainly present and used on a regular basis. The two most common ones are those antidepressants of mirtazapine and amitriptyline. And certainly we use these not infrequently in the right patient cohorts, and they tend to be the ones that also have features of mood disorders such as major depression. There is an effect. The mirtazapine effect tends to be up until doses of 7.5 to 15 milligrams, and then can actually have a counter effect once we get above those doses. But there's certainly been studies to show that it improves total sleep time as well as sleep quality when the mental health disorder is also present. And so when should you consider referring to a sleep physician? Well, I think it's important when the diagnosis is unclear, when you're considering that there might either be another sleep disorder, because as we showed, or as we said, insomnia alone, when treated in the presence of another sleep disorder, very rarely improves. If the insomnia is complex, and by that we mean insomnia that is associated with other medical and sleep conditions, or when you've gone down the pathway that we've just described and there's been failure to achieve the desired result. And so in summary, we talked about insomnia being the inability to fall asleep or maintain sleep, but most importantly, it's in conjunction with impairment in daytime function. And typically it's in the absence of other medical or sleep-related disorders that could be explaining those symptoms. There's significant health impacts associated with poor sleep quality and duration. So as a result, insomnia is an important condition to recognize and treat. Prevention is certainly the best management, but sleep hygiene plays a big role in both that as well as the first line management of insomnia. When sleep hygiene alone has been unsuccessful, then the behavioral therapies are far more effective than medications in the long term, but do require a lot of discipline. We can use medications, but ideally only for short periods of time and intermittent use only. And when there's complex insomnia or failure to improve, engaging a sleep specialist can certainly help to determine the correct diagnosis as well as the best treatment plan. Thank you very much.